Hi, good evening. Happy summer evening. Happy almost Juneteenth. My name is Dr. Maria Sophocles, and you're listening to and watching Gynecollege, which is our live stream show from Women's Healthcare of Princeton. And we're coming to you to try to address and discuss women's healthcare issues that affect uh, so tonight we're talking about fibroids, which affects so many women, such a common condition and a common problem for women of all ages, races, creeds, everything. Fibroids do not, they are colorblind, and they are a big source of morbidity and mortality, as we say in medicine. So tonight I am going to try to shed a little light for those of you who know a little bit about fibroids, to teach you a little bit more, and for those of you who know quite a bit, to serve as a place where you can ask your questions. So I'm going to start by just a quick fact, something I knew but had forgotten just how common they are. Fibroids affect 70% of white women and 90% of Black women. So, overall, approximately 80% of all women will have fibroids at some point in their lives. Now, this does not mean 80% of women are going around with heavy periods and anemia and infertility and pain. Fibroids can really vary from a tiny little single muscle cell to something massive that's distorting the uterus and causing tremendous pain and bleeding. So, what exactly is a fibroid? A fibroid is a benign, non-cancerous growth that can be started from a single muscle cell. They're made of smooth muscle, and they can stay tiny and seed like and literally go undiagnosed a whole woman's life. And in the era before ultrasound, many women with fibroids never even knew they had them. But now, because ultrasound has become a very common resource in doctors' offices and hospitals, many women who are seeking treatment for heavy bleeding or infertility or pain or urinary symptoms are diagnosed with fibroids. Fibroids come in different shapes and sizes, and they're classified based on where they are in the uterus. So, if a fibroid is sitting on top of the uterus, kind of sitting up around the outside cavity of the uterus, we call that subserosal. The serosa is the outer surface of the uterus. If it's on a little stalk and is attached to the uterus by a little stalk, we call that pedunculated. If in fact the fibroid is embedded into the muscle of the uterus, we call that intramural. And if it is within the cavity of the uterus, sort of where the baby would grow, we call that submucosal. Why does it matter? Why do we need to know the different types of fibroids? We need to know because depending on what type you have, this may be affecting why you have bleeding, don't have bleeding, or why you have pain or don't have pain. Because a submucosal fibroid, for example, which is inside the cavity of the uterus, is often a source for terrible bleeding. It's often a cause for repeated miscarriages, but it doesn't necessarily make pelvic pain, backache, urinary symptoms because it's not outside, it's not enlarging the uterus. A subserosal fibroid, on the other hand, or an intramural fibroid, could grow and make the uterus very large and therefore make symptoms of pressure, pain, especially back pain or pain with intercourse, or press on the bladder and make urinary frequency or urgency. Intramural fibroids can do either. Pedunculated fibroids usually act like subserosal fibroids. So it is good, and I wish I had a diagram to show you guys, but if you go to a website, I'd like you all to know about this website anyway. It's called the White Dress Project, all one word, thewhitedressproject.org. The White Dress Project is a nonprofit that was started to address the very common, very debilitating what they call epidemic of fibroids. So the White Dress Project's mission is to educate and empower women about fibroids, to dispel myths, to help women understand treatment options, and basically to take charge of problems in their lives related to their fibroids. So if you go on the whitedressproject.org, you'll learn more than you ever even knew you could learn about fibroids. So again, let's review those types one more time. Intramural fibroids are within the muscular walls of the uterus, and they can cause heavy bleeding or pressure symptoms. A submucosal fibroid is either inside the uterine cavity or just abutting right up into it, and it usually causes heavy bleeding. This is the least common type of fibroids. A subserosal fibroid is on the outer part of the uterus, and that typically just causes pressure symptoms or symptoms of bulkiness. And pedunculated fibroids are on a thin stalk attached to the uterus. So I think let's talk about symptoms now. And by the way, if any of you listening have questions, you can ask at any time. You don't have to wait till the end. Usually we ask our listeners to wait to the end because we have a guest speaker. Today, it's just me. You can interrupt me anytime you like. Talking about symptoms, I've listed a whole bunch of them here. Pelvic pain, irregular bleeding. Why is the bleeding irregular? It's irregular because the fibroids have a mind of their own. So they don't bleed according to schedule like a period. A period is a very specific bleed that is on a schedule because your body is growing endometrial tissue, and then the estrogen level drops and the progesterone level rises. And this is a signal to shed the endometrial lining that has grown if, in fact, there's been no fertilization. So that's really what a period is. Fibroid bleeding happens with no warning. It happens in completely irregular and unpredictable ways. And this can just add to the misery and frustration that comes with unscheduled bleeding. So symptoms of having fibroids are irregular bleeding, heavy bleeding, pelvic pain, back pain, pain down the legs, urinary frequency, going frequently. If the fibroids are growing in a forward direction, they're sort of growing towards your belly button and towards your bladder, this will make the bladder feel full with just a little bit of urine in it. So patients come in and they say they go to the bathroom very frequently because their fibroids are pressing on the bladder. The same thing can happen in the back. A fibroid can grow sort of out of the back of the uterus towards your spine. And if it does so, it can give lots of back pain, and that back pain can travel down your legs. It can also press on the rectum, so that even having a bowel movement is an incredibly painful thing. I have many patients who come in and say that when they go to have a bowel movement, they literally are in tears. And that's because the big fibroid is pressing so hard on the rectum. Other women will get constipated and have trouble evacuating their stool. So the other thing that if fibroids get big enough is, frankly, they can make your belly look big, like you've gained weight. And I have patients who come in saying, I don't understand. I'm not eating anything more than I usually do, but my belly's getting bigger and bigger. And we go to examine them, and the uterus is huge, the size of a football or 2 footballs. And these are big, giant fibroids, just completely distorting the whole abdominal cavity. So let's say one more time: symptoms of heavy bleeding, a feeling of fullness or belly enlargement, pain during sex, okay? Because when you have sex and the cervix is hit by the penis, then that causes pain that gets transmitted all up into the abdomen. Complications during pregnancy and labor. We didn't really even talk about that yet, but even infertility. So you can have trouble getting pregnant, and you can have trouble staying pregnant, and you can have trouble delivering the baby. Trouble getting pregnant or infertility usually happens if there's a submucosal fibroid. If there's something in the cavity of the uterus, then the egg can't implant in the walls. Or as the embryo begins to grow, it's competing for space with the fibroid uterus, and it simply can't grow, and women have miscarriages. So when women have miscarriages repeatedly, especially early miscarriages, we often worry about fibroids and we'll do an ultrasound to look for a submucosal fibroid. So that's the initial way we diagnose fibroids is a pelvic exam and an ultrasound. The pelvic exam is a bimanual exam. That means one hand has a finger or two fingers in the vagina, other hand on top on the tummy, pressing on the abdominal wall, trying to feel where is the top of the uterus. In a normal, non pregnant woman with no fibroids, the uterus is only about that big, and the belly is just around the fibroid is just around the pubic bone. So it's very, very small. But in women with enlarged fibroids, we can feel the fibroids between that pubic bone and the belly button somewhere. In women with very large fibroids, the uterus and fibroids are so massive that they're as up all the way to the belly button or even higher. I've had patients where their fibroids were so big they were under their rib cage. Um, these women have incredible discomfort. So, getting back though to complications that fibroids cause with pregnancy. So, getting pregnant is one very problematic fibroid complication. And as I said, getting pregnant is impaired when you have a submucous fibroid, one inside the cavity. Well, what about if you get pregnant and there's no submucous fibroid, but you have them throughout the muscle? Then you may go along and have a pregnancy that is doing just fine. But as the uterus grows, if there are fibroids in there, they often are irritating the uterus as it's getting towards its second or third trimester. And frankly, space becomes an issue. The belly outgrows the space that the uterus needs. Or I guess the uterus outgrows the space that the belly provides. A better way to say that. And women will get preterm contractions and sometimes go into preterm labor and sometimes deliver the baby early. So fibroids can be really problematic, not just for getting pregnant, but for staying pregnant and keeping the pregnancy until the baby's full term. For this reason, many women who have fibroids, and now we know more women have fibroids than we used to know because of ultrasound. So many women who have fibroids will elect to get the fibroids removed before they get pregnant. Now, this isn't a hysterectomy. We can't remove the uterus or else they can't get pregnant. This is a robotic myomectomy. Myoma means fibroid, right? Myoma is the medical term for fibroid. So a myomectomy is the medical term for the surgery that means just taking the fibroids out and leaving the uterus in. So I'll put that on the banner in a second. So many women choose to have a myomectomy. So a myomectomy can be an open incision, a big incision. And when I trained in the 90s, that's how we used to do it. We didn't have any other way. But then along came something called laparoscopy. And laparoscopy allowed us to remove the fibroids through the belly button. So now we do laparoscopy and laparoscopically do myomectomies, which is great. Often help with a robot. This is the newest, fanciest way to do a myomectomy. So we call this a robotic myomectomy. And a robotic myomectomy allows women to have their fibroids removed and go home the same day. So a robotic myomectomy is a type of laparoscopy where we use a robot to help us, and it allows the fibroids to be removed through the belly button, and women go home the same day. So that's just been tremendous because it cuts down on blood loss, it speeds up recovery time. And for many women, having a robotic myomectomy allows them to get pregnant and stay pregnant and have a pregnancy that goes full term. A question I often get asked when I'm talking to women about fibroids and doing surgery is, if I have the surgery, does that mean they'll never come back? Unfortunately, that does not. So fibroids can recur and do recur. We don't have any crystal ball or any blood test or any x-ray or mammogram or anything that can tell us whether your fibroids are going to come back or whether they won't. And I've been taking fibroids out for 26 years, and I would love to have a way to be able to tell women whether they should plan that their fibroids will be returning or not. But there's absolutely no way. It's not age dependent or race dependent. It's not dependent on the size of your fibroids or the number of your fibroids. So surgery does not definitively keep fibroids from ever coming back. That's just the truth. Um, Patients always ask me, look, Dr. Sophocles, I don't want to have surgery. Is there another way to totally get rid of the fibroids? And the answer is no, there's not another way to completely remove the fibroids, but there are other treatments for fibroids. There are medical treatments and there are ablative treatments. So the three types of ways we sort of deal with fibroids to either shrink them, make them less of an issue, or remove them are medications or surgery or radiofrequency ablation. And I'll talk about that in a minute. So medications that can, let me just type this over here. Medications that can um, help with pain and bleeding from fibroids are usually medications that reduce estrogen in the body because fibroids are fed by estrogen. So food for fibroids is estrogen. So anything that will control estrogen in the body, especially reduce it, will help us with fibroids. So now there are medications, and Orion is one. It is a brand name, but you can look it up, and that way you can read about it and learn about it. And you're welcome to email me with questions or me through practice at princetongyn.com. Orion is a medication that we give. It's a tablet taken every day, and it acts sort of as an anti-estrogen. So there are some sort of hot flash type of side effects with it, but the side effects are very well tolerated. They're very minimal compared to the benefit that it gives women with fibroids. It reduces the bleeding from fibroids by 80%. So you bleed a lot less, the fibroids shrink, and you feel them a lot less. So it's just been really a godsend for those of us that treat fibroids. Um, Birth control pills are another simple way to control bleeding um, related to fibroids. Why? Because birth control pills reduce the amount of tissue that grows inside the uterine cavity. So your periods get much lighter. So birth control or hormonal medication are tried and true treatments for fibroids. There are also medications called GnRH agonists, and those are medications which also sort of act in an anti-estrogenic fashion to decrease the food that feeds the fibroids. So none of these are perfect, if I'm honest. Okay, none of them make the fibroids go away, and none of them are completely without side effects. But often they're a really nice band aid that you can take for a few years if you're almost to menopause, or a nice band aid or preparation for surgery. Many people say, look, I want to have the surgery, but I can't have it till the fall, or I can't have it till my insurance changes, or I can't have it till my kids are in school. And so we'll use these medications for a few months while they're waiting for their surgery. There is another procedure that I think is important to know about. This is not surgery, but it is called uterine artery embolization. So, uterine artery embolization is a procedure not done by a gynecologist, it's not surgery. It's done by an interventional radiologist. An interventional radiologist is a kind of radiologist who does procedures to correct things, to fix things, to cure things. And an interventional radiologist can thread a little catheter into your leg, believe it or not, into a big artery in the leg, then goes to the uterus, and he injects something that actually, think of it like little beads, And these little beads actually block the blood flow to your uterus, to the fibroid. And the fibroid gets its blood supply cut off, and sure enough, it shrinks. And I've seen fibroids shrink 30 or 40%. So while this isn't the same as removing them, it may be enough to relieve you of some of the miserable symptoms that you're experiencing. So I've had many patients, especially women who weren't good candidates for surgery, who had other medical conditions or just didn't want to have their surgery, have uterine artery embolization. You spend the night in the hospital, that's to be watched and to have some pain control. And then you go home the next day, you have a little incision in your leg with a band-aid. And the recovery is fairly straightforward and easy. And again, not perfect, but if it will shrink fibroids by 30% or so, maybe that's enough to give you the quality of life you're looking for. We have a question, so I'm going to take this question from Keisha Dennis. Are there any good medical options that can be taken with a SERM? So, gosh, Lakeisha, that's such a good question. Okay, so first we have to define for other people what a SERM is. Selective, so I'm going to type it, estrogen receptor modifier. So this is what SERM stands for, SERM, selective estrogen receptor modifier. These are medications, they're not hormones, but they will turn on or off estrogen in certain parts of the body. One of the most famous SERMs is tamoxifen. And tamoxifen is used, as I think a lot of you know, for women with estrogen receptor positive breast cancer. So it turns off estrogen in the breast. So it prevents these women from getting breast cancer again. And it's super, super important. It's been a super important way that we've prevented a lot of breast cancer from recurring. So, Keisha, your question was what medication options can be taken with a SERM? And I guess the answer to that is that probably Orion can be taken, ORIAHNN, should be able to be taken with a SERM. I'll double check to be sure, and I will let you know. But that should be fine to take with a SERM. To be honest, you can, if you had to, you could take hormonal medications with a SERM because if there's any estrogen in that preparation, it's just um, uh, nope, that's wrong. You can only take those if you're on a aromatase inhibitor. That's a different breast cancer medication. So I think the best medical options would probably be either the Lupron, the GnRH agonist, or the Orion, which I mentioned before. But there are a lot of things in development, so stay tuned because there's a lot of money being used for development of non-hormonal options for fibroids. So I think the answer to your question is the Orion, ORIAHNN, hard to spell, and the GnRH agonist. As far as I know, they're both okay to take. Good question. Any other questions? Otherwise, I'll kind of keep going because I think we talked a little bit about surgical treatments. Okay, so surgery everybody's heard of, and you understand that you could have a myomectomy. You could also have a hysterectomy. So why would you have a hysterectomy? Well, many women say to me, I don't want a hysterectomy because then I'll be in menopause. This is one of the biggest myths out there. Having a hysterectomy does not mean you necessarily will be menopausal. Surgical menopause happens when we remove the ovaries, not the uterus. That's a huge source of confusion for a lot of women. And I think the reason it was confusing is that years ago, when women had their uterus out, they often always took the ovaries out. And so all the women who had a hysterectomy became menopausal and hot flashes and gained weight and became miserable and were just so unhappy. So a lot of women were taught that if you have a hysterectomy you will be in menopause. Not true. You can have a hysterectomy and remove the uterus and the fibroids and you will never ever get a uterine fibroid again after that. The tubes will come out, and that's okay. The tubes are a big place where cancer starts anyway, and you don't need your tubes. They don't do anything for you, the fallopian tubes. The ovaries, in many cases, are left behind. Why? Because the ovaries are hormonally active, and we want you to keep having estrogen and progesterone and testosterone as long as the ovaries are working. And that's usually till around 51 to 52 years old. So if you're 42 and you're finished having kids and your doctor says, I think hysterectomy would be a good idea for you, don't immediately put your hands up and say, no, I don't want to be in menopause. Because that doctor, if they're worth their salt, will say, hey, we can leave the ovaries behind. You can have a decade worth of health benefits from them. We can take the uterus out, and your bleeding and pain and painful intercourse and back pain is all going to go away. So before you put your hand up and say, no, no way, don't want a hysterectomy, make sure you advocate for yourself and say, well, I'm not sure whether I want a hysterectomy. I might or might not, but I know I don't want to be made surgically menopausal. Now, if you're 50 years old, that's a different story. Your ovaries have almost no lifespan left in them. And most of us feel that taking them out at age 50 and over probably serves you well because now, yes, you're menopausal, but you were about to be menopausal anyway. But now we have removed two little time bombs from your body that were very hard to diagnose in terms of cancer. I'm talking about ovarian cancer. So if you're 50 or over, especially if you're past menopause, and you decide to have a hysterectomy because your fibroids are causing you tremendous discomfort, don't worry that taking the ovaries out is going to do something bad for you. It's not. It's actually only going to do something good for you because it's only going to decrease your risk of another cancer. Okay, so one thing I want to get to before we finish are risk factors. Okay, we talked about types of fibroids. So we don't know the exact cause of risk of fibroids, but we do know risk factors that increase a woman's risk of developing them. So I've listed some of them here. So let's start with age. Fibroids are more common as women age, especially during the 30s and 40s and then through menopause. After menopause, they usually shrink. Now, this doesn't mean they're going to shrink like this and become super tiny, but they may shrink some. It's another big myth is many patients say, well, I don't want to have a hysterectomy. I'll just suffer for 15 years because as soon as I'm in menopause, they're going to go away. Not so. They often will shrink some, but maybe not enough to relieve you of the pain that you're feeling. Having a family member with fibroids does increase your risk. So the next risk factor is family history. If a woman's mom has fibroids, she has about a 3 times higher than average risk of having fibroids herself. Okay. The next risk factor is ethnicity or ethnic origin. African American women are more likely to develop fibroids than white women. What about obesity? Women who are overweight are at higher risk for fibroids. Why? Because remember what I said, estrogen is food for fibroids, and estrogen is stored in fat cells. So if you are obese, you have more fat cells, and so you have more estrogen to feed those fibroids. Okay, not fair. Same reason that if you're obese, you're at higher risk for endometrial or uterine cancer. That is also fed by estrogen. So if you're looking for a good reason to lose weight, decreasing your risk of uterine cancer is a great one. Decreasing your risk of breast cancer, another great one. And now you have one more reason, decreasing the likelihood of you feeding and growing your fibroids. So eating habits. This sounds weird because why should what you eat affect fibroids? But we know that eating a lot of red meat and even ham can increase the risk of fibroids. So somebody studied it. And then there is a protective effect. Believe it or not, I'm not making this up. Eating green vegetables has been shown to be protective against developing fibroids. So when your mom was on your case about eating your vegetables, she may not have known she was teaching you about fibroid healthy dieting, but she was. What about vitamins? Vitamin D deficiency is a risk for fibroids because Vitamin D is a powerful inhibitor of fibroid growth. And only 10% of African American women have adequate vitamin D. So, wouldn't be crazy the next time you're at your gynecologist or your primary care to ask them to draw a vitamin D level. Many of us have inadequate vitamin D, partly because we need sunshine to have our vitamin D activated. And so many of us have indoor jobs, and we go from our car to our indoor job to our work to our car back to our home, and we're indoors all the time. So moderation is what I'm talking about with sunlight. I'm not talking about tanning. Nobody should go get their, um, remember those aluminum kind of tanning things. We don't want any sun damage, but I do think a moderate amount of exposure to sunlight to activate your vitamin D is helpful. Vitamin D supplements can be helpful if, in fact, you need them. And then the best, vitamin D from food sources like salmon can be a super great way to make sure you're doing everything you can to inhibit the likelihood of your fibroids growing. I think that's most everything I wanted to tell you all. I did want to hit on this one new procedure that's available called the Acessa procedure. Acessa procedure is a surgical procedure, but it's different than robotic myomectomy. It's using radio frequency to heat up and ablate and destroy a fibroid. So we do it laparoscopically. Again, we make an incision in the belly button and another incision in the body, and we use ultrasound, and the ultrasound guides a little probe into the fibroid. We connect that probe to radio frequency wavelength energy. The radio waves actually heat up the fibroid and destroy it, and it shrinks. Um, it's pretty neat because we don't have to take the uterus out. It's done as an outpatient procedure, but you do need anesthesia. You do need to go to the hospital. You do need to go to sleep. This is being offered now at many major medical centers, and you can always look up Acessa Procedure online and find where they on their website they have a way for you to look up and see where it's being done and who's doing it. And Yeah, we have another question. We'll do that. So anyway, cool, neat procedure. There's so many neat new things coming down the road for fibroids. So stay tuned. What's the question, Sam? Okay. I've been diagnosed with neurofibromatosis. Would that be an increased risk factor? Not that I know of. That's a great question. My gosh, you guys are asking great questions. I know the word fibroma is in there, and that does sound like fibroid. But to the best of my knowledge, people with neurofibromatosis do not have increased risk of fibroids. Um, so I hope that answers your question. If you could also get an ultrasound. You could ask your doctor for a pelvic ultrasound, and that would certainly be able to tell you. Um, there was another question, so I think we'll go to that. Is the ultrasound procedure fertility preserving? Yes, that was the next thing I was going to say, Lakeisha. Thank you so much. Is the ultrasound guided radio frequency procedure? The cool thing about that is the uterus stays in place. So for patients who have fibroids, want to have a baby, but just really wish those fibroids would shrink and don't want to use medication to have them shrink, it is fertility preserving. That means you can conceive after that. You can conceive after robotic myomectomy as well, remember. Um, it's just there is a several month lag period where the stitches from the robotic myomectomy have to dissolve, the scar has to form. And so even after a myomectomy, you can have babies after that. Any other questions? You guys ask such good questions. Are different procedures more recommended for certain types of fibroids? Yes, excellent, excellent question. So remember, I talked about the different types and where they are. So if you come to me and you have fibroids on the inside and outside, and you say, well, I don't really have much back pain, but I want to have a baby, then the most important thing is getting that fibroid out that's inside the cavity. So that's what we would do, a hysteroscopic myomectomy. We would use a hysteroscope, hysteroscopic, I'm going to type this, myomectomy. This is where we would take submucous fibroids out through the vagina. The camera goes through the cervix into the uterus. Out of the camera comes a little instrument to get rid of the fibroid. So hysteroscopic myomectomy is what we do for submucous fibroids. For fibroids that are in the walls and causing pain and pressure, we do a myomectomy, or we can do radiofrequency ablation. For fibroids where the patient just wants them to shrink a bit, we can use medication. So it depends on, and you're not really going to know what your clinician's going to recommend until you know sort of the map of your fibroid. So that's the first thing. Come in, have a pelvic ultrasound, and have a pelvic exam, and then an ultrasound. And any good clinician should be able to draw you. Here's your uterus. Here's this fibroid. Here's that fibroid. Fibroids. Ultrasounds are so specific now. They can tell you so much. They can tell you exactly how many and exactly what size. And serial ultrasounds, one after the other, they can tell you if they've grown, shrunk, or stayed the same. Sometimes surgeons will get MRIs to even know more precisely exactly where a fibroid is, so that before the surgery, they can discuss with you what procedure they recommend. For example, do they recommend taking the cervix out or leaving the cervix behind if they're doing a hysterectomy? Sometimes when I do a hysterectomy, we try to leave the cervix behind, only to find once we're in the operating room that one of the fibroids is grown very low and is completely taken over the cervix. So the patient will wake up and the cervix is gone, as well as the uterus. So these are all important questions to ask your doctor. If you're thinking of doing a hysterectomy, is this supracervical, above the cervix, or are you planning to take the cervix? And if so, why? Where's the fibroid that says you have to take the cervix out? So yeah, different procedures are recommended for different types of fibroids in different locations. Good questions. Any other questions? My gosh, you all asked really good questions tonight. Thank you for listening to me babble for 30 minutes. It's really weird to not have a guest, but there was so much to say that I felt that it would just be easiest to just get this out there. Again, if you have other questions, you can go to princetongyn.com. I'm Dr. Maria Sophocles, and this has been an episode of Gynecollege. You can always look for our subsequent episodes. Our next episode is about gender transitioning and what people who are questioning, considering, changing their gender can expect physically, emotionally, resources, procedures, care. We'll come next time to look back at our old episodes. You can go on YouTube and you can just type in Gynecollege and you'll find them. Get some popcorn, watch a few. I think you'll learn something. Again, I'm Maria Sophocles. Thank you all so much. Have a good night. Have a great summer. Happy Juneteenth, a little bit early. And yeah, let me know if I can help you. Bye.